This is ADHD Differential Diagnosis, a course presented by the Mindful Ecotherapy Center at mindfulecotherapy.org. Course Overview. In this course, we'll be discussing the ADHD epidemic, comorbidity, which is ADHD and other diagnoses, then is ADHD overdiagnosed, and finally, a course summary and review. Let's begin by talking about the ADHD epidemic. Globally, the prevalence of persistent adult ADHD was 2.58%, and that of symptomatic adult ADHD was 6.76%. That translates to nearly 140 million and 366 million affected adults in 2020 globally. That comes from Song 2021. That's in your references for the course. Additionally, 5.1 million children, or 8.8%, or 1 in 11 of the age group 4 to 17 years, have a current diagnosis of ADHD. 6.8% of children ages 4 to 10, or 1 in 15, 11.4% of children ages 11 to 14, 1 in 9, or 10.2% of children ages 15 to 17, or 1 in 10. And that's according to the National Survey of Children's Health, 2016. You notice that the children's group is 4 to 17. You cannot diagnose a child with ADHD younger than the age of 4. So the global prevalence is around 1 in 10. So why a course on differential diagnosis? ADHD symptoms overlap with the symptoms of many other disorders, and sometimes diagnosis focuses on the inattentive aspects without looking at the full spectrum of the disorder, the hyperactive and other symptoms. Inability to pay attention is a symptom of many other diagnoses as well as ADHD. Let's talk about comorbidity, ADHD and other diagnoses that have similar symptoms. There are several factors you should consider when diagnosing ADHD. First, the psychological aspects. Could it be another disorder with symptoms similar to ADHD? Then there's the general medical conditions. Could the symptoms be better accounted for by a medical condition? Environmental factors. Are the symptoms the result of the patient's environment? And are the symptoms present globally or specifically? In other words, do they show up all the time, or do they just show up under certain conditions? Finally, comorbidity. Are there other things going on in addition to the ADHD, or instead of the ADHD? Let's start off by looking at the psychological factors. There are several different diagnoses that have similar symptoms to ADHD, so let's rule them out before we make a diagnosis of ADHD. First is generalized anxiety disorder, and that's defined as worry for 6 months or more that cannot be controlled, a lack of energy, anxious mood, and somatic anxiety symptoms. So you can see that there are some very similar ADHD symptoms that could be covered by generalized anxiety disorder. Obsessive compulsive disorder, and that is obsessions or compulsions that interfere with the level of functioning, or ADLs, activities of daily living, in other words. Are you able to function on a daily basis? Major depressive disorder, and that includes an episodic decline in the mood or depressed mood and or dysphoria, suicide-related issues, suicidal ideation and suicidal attempts, and then low energy or psychomotor retardation. Another psychological factor is bipolar disorder, which includes episodic change from baseline behaviors, psychotic symptoms, grandiosity, pressured speech, recent decreased need for sleep without loss of energy. And you can see there as well that ADHD has some symptoms that are similar to bipolar. especially that pressured speech aspect. Then there's autism spectrum disorder, which is a qualitative impairment in social interactions or communication, or odd or eccentric behaviors. Also, oppositional defiant disorder, which is defiant, anger issues, frequently losing temper, deliberately annoying other people's, hypersensitivity, spiteful, and are vindictive. And so if you've worked with people who have the hyperactive aspects of ADHD, you can see how that might cross over into oppositional defiant disorder as well. And then conduct disorder, which is aggression to people and or animals, destruction of property, deceitfulness, theft, serious violations of the rules. Disruptive mood dysregulation disorder. That includes severe, recurrent, disproportional temper outbursts, verbal and or physical, occurring 3 or more times per week in at least 2 settings for 12 months or more. Diagnosis is first made between 6 and 10 years old in most cases. And again, you can see how that might be similar to ADHD, especially with the mood dysregulation. ADHD people sometimes have difficulty regulating their moods or knowing appropriate ways to express their moods because of that impulsivity. Substance use disorders. Positive substance abuse screens are history of substance abuse or use, family member with history of substance abuse, or prescription of psychotropic medications. Now, what does that mean? Just to clarify, when doing a diagnosis on a child, I always check to see if the parents are on any medications, because children sometimes will steal medications of their parents to experiment. And then if they're on psychotropic medications, the parents that is, and the child is taking those, then of course that's going to affect the child's mood, temperament, impulsivity, and all of those things that can be diagnosed as ADHD. Also check for prescriptions for mood stabilizers, decongestants, or beta agonists. And beta agonists, if you don't know, are medications that relax muscles of the airways, which widens the airways and results in easier breathing. And all of those can make you anxious and make you present with symptoms similar to ADHD. Check for learning disorders, and that includes learning disabilities or emotional disabilities identified by assessment. Children with learning disabilities are going to be behind the rest of their classmates usually, and when that happens, they're going to be frustrated, and that frustration is going to manifest as ADHD symptoms, or ADHD-like symptoms, I should say. Language disorders. And that requires consultation with speech and language pathologists to confirm the presence of a language disorder. Next is tic disorders or Tourette syndrome, and that includes vocal or motor tics prior to medication. And note also that stimulant medications can cause tics, and they do in about 50% of cases according to NAM in 2022, and that citation is in your references for the course. Be aware that it's very common for children especially to start taking ADHD medications and to develop motor tics. If you're doing a differential diagnosis for tic disorder or Tourette syndrome, make sure to notice when the motor tics are present. In other words, check for motor tics before the child gets on ADHD medication. Next is borderline personality disorder. And as you're probably aware, you cannot diagnose borderline personality disorder until the child is 18 or older. But just for the symptoms include abandonment anxiety, hourly mood fluctuations, suicidal ideation or suicide attempt, parasuicidal behaviors like cutting on their skin, cutting their wrists, that sort of thing, identity disturbances, dissociative symptoms, micropsychotic episodes, seeing things, hearing voices, religious delusions, that sort of thing, chronic feelings of emptiness. Now, just because a child is under 18, that doesn't mean that the child can't manifest these symptoms. You just can't diagnose borderline personality disorder until they're 18 or older. And also, consider the fact that if you're working with adults, it might also be borderline personality disorder. And you can see that some of the symptoms of ADHD might be included in this, like identity disturbances, hourly mood fluctuations, that sort of thing. Antisocial personality disorder. And of course, again, the person must be over 18. If they're under 18, you would look at the symptoms for conduct disorder. The symptoms for antisocial personality disorder that might be relevant to a differential diagnosis of ADHD: lack of remorse, lack of personal responsibility, lack of empathy, lack of conscience. In people with antisocial personality disorder, those are the symptoms that are diagnostic of that. With ADHD, it can sometimes manifest in those symptoms. Not necessarily that they have a lack of remorse, it's just that their impulsivity might not allow them to express it. Same with a lack of personal responsibility and a lack of empathy and a lack of conscience. It's not that a person with ADHD doesn't have a conscience, it's just that sometimes the impulsivity causes them not to be able to express it in appropriate ways. Now let's look at some general medical conditions for differential diagnosis of ADHD. The first is head trauma or concussion. And of course, that can lead to impulsivity, inability to pay attention, all of those symptoms for ADHD. So you want to also screen for a history of head injury, accident, falls, or severe abuse. If you're diagnosing a child and the parents routinely abuse the child physically, especially in the head area, then you want to check for that. And of course, traumatic brain injury as well. A history of seizure disorders that can contribute to a diagnosis of ADHD. Patient history of seizures are also a family history of seizure disorders. It could be that if you're diagnosing a child, they haven't had a seizure disorder yet, but if they have a family history, they have a genetic propensity to possibly have one. Hearing or visual impairment, and this is important as well because the differential for ADHD there is that if you're not paying attention, it could just be because you're not hearing your teacher or you're not hearing your boss, depending on whether you're working with an adult or a child. Or visual impairment for the same reason. If you can't see, for example, the chalkboard, or if you can't see the presentation board at work, then you're going to have a difficult time paying attention to what's actually being said. And then you can always rule that out by doing a test for hearing impairment or vision impairment. If you're doing children, get the date of the last hearing test or eye exam to make sure that there are no issues there. Then thyroid problems, which can replicate symptoms of ADHD. So check if there's a family history of thyroid difficulties. Next is diabetes. And we're going to look at some of the characteristics there. Family or personal history of diabetes. And some of the symptoms if the person has never been diagnosed with diabetes. It's malnutrition, hunger and nausea, sweating more than usual, anxiety, confusion, or other changes in behavior. And you can see there where that might be a symptom of what might be misdiagnosed as ADHD. Tachycardia, in other words, fast heartbeat, general overall weakness, occasional intermittent blurred vision, dizziness or lightheadedness, or headache. Now, I'm assuming that if you're a mental health professional taking this course, and not a medical professional like a doctor, that you're not going to be qualified to diagnose diabetes. So you would refer them to their family doctor, or just at least do a family history to see if there is any family history of diabetes, so that you can rule out any differential diagnosis regarding ADHD. But again, don't attempt to diagnose diabetes yourself. Refer them to a medical professional and let that decision be made by them. And here's the differential for diabetes. Are the behaviors present only sporadically? In other words, are they there a lot? Or are they there globally all the time? Or are they only showing up every once in a while, like when the blood sugar is low? Do the behaviors seem to occur shortly before or after a meal? And again, that's an issue with blood sugar. Are there any patterns linking behaviors to diet? For example, exacerbated after eating high-calorie foods or high sugar foods. And the differential for ADHD is, are the behaviors present globally? In other words, in all situations and in all places? Do the behaviors seem to occur throughout the day? Now, I will say that if you're working with a child who has been diagnosed with ADHD and they're taking medications, there seems to be sometimes a period of adjustment to find out the right dosage on the medicine, so that right about the time they're getting out of school, the medicine seems to be wearing off. And so consider that as well. Consider what time the symptoms are showing up throughout the day to differentiate between ADHD and diabetes or any other physical problem. And then finally, there are no patterns linking behaviors to diet, for example, exacerbated after eating high calorie or high sugar foods, as we already discussed. Next general medical condition that can emulate ADHD behaviors is severe anemia. And this would be differentially diagnosed by medical exam. If they've already had a physical recently, then you might request their medical records or just ask them what their medical history is, and then you can rule that out. Some of the symptoms of severe anemia are irritability, shortness of breath, unusual food cravings or pica, change in appetite, loss of energy, sore tongue, headaches, dizziness, blue tinge or very pale whites of the eyes, brittle nails, and pale skin. And you can see there that some of those symptoms are similar to ADHD, especially irritability, change of appetite, loss of energy, those sorts of things. Next is lead poisoning. And you will need to rule this out with the help of a doctor or a physician or a nurse practitioner. And again, you would check the medical records or at least refer them to their family physician to rule this out. But the differential diagnosis by medical exam for lead poisoning is there lead paint in the household? So if you know of any neighborhoods in your area where they might have used lead paint, where they might have older houses that have done that, check for that. Exposure to environmental toxins. Are there any toxic environments in the neighborhood? Developmental delays. Learning difficulties, and there is one of those diagnostics that is similar to ADHD. Irritability, again, another symptom of ADHD. Loss of appetite and weight loss, again, ADHD. Sluggishness and fatigue. Abdominal pain, vomiting, constipation, and hearing loss. So keep all these symptoms in mind as well when you're diagnosing ADHD to be able to differentiate. Next general medical condition is sleep disorders. And this usually includes apnea, but it can also include things like night terrors, sleepwalking, those sorts of things. First is problems with sleep, either sleeping too much or sleeping too little. Next is waking up multiple times during the night. So this could be also like a hyperactive bladder syndrome that's keeping them up all night. Problems falling asleep or staying asleep, and that could be caused by anxiety, depression, also diet, drinking too much coffee before going to bed, or eating a diet high in caffeine. Nightmares, as we've already discussed. Tossing and turning all night, which could be some sort of a physical symptom. Snoring, and that's a possibility of sleep apnea. And then a recent change in sleep patterns that might be leading to the symptoms. And while those symptoms directly don't seem to have too much to do with ADHD diagnosis, you can see how a lack of sleep is going to make you irritable, is going to make you impulsive, is going to make you not think things through so well. So again, that's where the differential lies. Now we're going to get into some things that are not quite as common, but they still need to be discussed just in case. First is Fragile X syndrome. And we'll go over these symptoms. First is narrow face, a larger head than apparently normal, larger ears, flexible joints, flat feet, a prominent forehead, difficulties with speech, difficulties making eye contact, family history of Fragile X, and then confirmed by genetic testing. And of course, if you're working with adults, most adults will probably have been diagnosed with this already if they're going to have it. But if you're working primarily with children, then you want to make sure that you rule this out as well. Even though it's very rare, it's still a possibility. So just keep that in mind. Next is fetal alcohol spectrum disorder. And this is a little more common than Fragile X, but not quite as common as some of the other general medical conditions that we've talked about. But let's just go over the characteristics. First is short palpebral fissure lengths. And if you don't know what that is, then you can look at the picture here and get an idea. The smooth philtrum. The philtrum is the area between your nose and your lip, where that little cleft is in most people. That is not present in a baby with fetal alcohol syndrome. A thinner upper lip. Growth deficiencies, in other words, they don't develop as rapidly as other children. And then also evaluate prenatal alcohol exposure risk. In other words, do they have a parent? Did the mother drink while they were pregnant? Did the mother have a problem or a history of alcohol prior to becoming pregnant? And that gets into the history of substance abuse with the mother. And then the final differential diagnosis under general medical conditions that we're going to look at is neurofibromatosis. That is a physical condition. In a child, it's going to be 6 or more cafe au lait spots greater than 5 millimeters in diameter before puberty. And if you don't know what that is, that's just basically a brown spot on the skin. If you look at the picture here on the right buttock, you can see a small cafe au lait spot on the right cheek there. There's a darker brown area. And then after puberty, it gets to be greater than 15 millimeters in diameter. You can see that on the buttocks there of the one in the picture, that's probably greater than 15 millimeters in diameter. And they later develop into these neurofibromatosis lesions, as you can see. Now let's talk about environmental factors. This is probably the greatest source of ADHD-like symptoms. So you need to use extra care when doing a differential diagnosis here to be able to determine if it's a diagnosis that's causing the symptoms or if it's environmental factors that are causing the symptoms. The first is an unsafe or disruptive learning environment. If there's a lot of chaos in the child's house or in the child's home, then naturally it's going to be difficult for them to concentrate. It's going to be difficult for them to be able to avoid impulsive behaviors. If they're seeing impulsive behaviors at home in their home environment, then they're going to have difficulty learning how to not be impulsive themselves. And that leads to the family dysfunction. Is there any trauma going on in the house? Has the child witnessed anything that might have contributed to the symptoms? And that includes poor parenting. Is child abuse or neglect one of the primary sources of discipline, or corporal punishment one of the primary sources of discipline? And there is a thin line between corporal punishment and child abuse. Some would say that it's a non-existent line, that if you have to hit your child as a method of discipline, that you're engaging in child abuse. Now, whether or not you believe that, what the data shows and what the studies show is that children who have been subjected to a lot of corporal punishment display similar symptoms to ADHD. And now there's a chicken or egg question as well, because ADHD children tend to be more victims of corporal punishment because they have difficulties with impulses. And on the other hand, it could go the other way as well, that children who have experienced more corporal punishment display more ADHD-like symptoms. And then, of course, all of this above leads to attachment disorders. How is the child's attachment to parents, to family, to others, to support groups? If there are attachment injuries going on, then of course that's going to lead to poor impulsivity. Now we're going to zoom in a little bit on those points that we just talked about on the previous slide. Some ways to look at these things. So first off, the unsafe or disruptive learning environment. What you want to consider as you're making a diagnosis, is there any crime or abuse in the home? Is the child witnessing any domestic violence? Is the child a victim of any sort of domestic violence? Is there crime or abuse in the neighborhood? Maybe the things at home are okay, but they live in a dangerous neighborhood and they're witnessing a lot of violence on a daily basis. What about substance abuse in the home or substance abuse in the neighborhood? And also mental illness in the home. And you can do all of this through an assessment of family functioning. If you're a marriage and family therapist, you might be familiar with something called a genogram. And a genogram is basically a map, a roadmap of family interactions that can be used to assess family functioning. And if you're not a marriage and family therapist, you can find out how to do a genogram online. You can do some research and find out how to do that. And that's a great tool to use for the assessment of family functioning to help you to rule out any of these unsafe or disruptive learning environments that might be contributing to a diagnosis of ADHD. Next is family dysfunction. Does the family communicate well? In other words, what is their interactive style? Are they authoritarian or authoritative or permissive? And we'll talk more about that in a moment. Next, parentified children. And what that means is, are the children required to take on parental roles? You see this a lot in families where there's substance abuse. And what I mean by that is mom or dad is too drunk to make dinner tonight, so I've got to make dinner. Or mom or dad are too out of it or too under the influence of a substance to act as a parent. So then the child might have to act as a parent. Especially if they have siblings, the older child is usually recruited into the role of the babysitter and the adult in the situation to take care of the children. And while you usually see a parentified child in a family with substance abuse, it doesn't necessarily have to be. It could be other situations where the parents have absconded on their parental duties or parental responsibilities, like mental illness or just apathy or indifference, or other causes along those lines. Next is fusion. What fusion is sometimes called emotional fusion. That's where the parent and the child have become so fused emotionally with each other that the child doesn't know where the parent's emotions begin and the child's emotions end. How does that manifest in reality? What it looks like is where the parent is making the child responsible for the parent's well-being emotionally, or vice versa. They're telling their children that their feelings are wrong, that they shouldn't have feelings. It's their duty to make the parent happy emotionally. Or they're telling the child what the child should think and feel. And you can see how that could lead to impulsivity and to an inability to concentrate. Next is emotional cutoffs, which is the opposite of fusion. That is where the parent and child don't communicate emotionally. In other words, the child might feel emotionally cut off from the parent because every time the child tries to talk to the parent about feelings, the parent gives the message, whether intentionally or unintentionally, I'm not interested in your feelings. I'm not interested in how your emotions are playing out. Your emotions are not important. So if every time I try to tell you about my emotions, you ignore me, then eventually I'm going to get to a point where I'm emotionally cut off. In other words, I'm not capable of expressing my emotions because every time I try to, you ignore me or minimize my own feelings. And you can see how when that is turned inwards, that can also lead to impulsivity and problems along those lines, difficulty in concentrating, and all those ADHD symptoms. Because if my feelings don't matter, then it doesn't matter if I choose to express them appropriately or not. So that's going to lead to impulsivity. Next is triangling. For those of you who are not marriage and family therapists, triangling is, I always refer to it as monkey in the middle. Say you've got two parents that can't get along with each other. So they recruit a child, and it's this triangle formation to be the go-between. Go tell your mom I said this. Oh yeah, well go tell your dad I said this. So the child is caught in a difficulty between parents, and is asked or expected to act as the referee. And when the child is put in the role of modulating the parent's emotions, then they have difficulty trying to figure out what their own emotions are. You see a lot of fusion with these triangling situations. So when a child has difficulty identifying all these emotions and being responsible for their own emotions, you can again see how that might lead into the impulsivity that is often misdiagnosed as ADHD. And then finally, family secrets. Families with a lot of secrets can lead to the child having symptoms similar to ADHD. The reason for that, of course, is simple. If I'm not able to talk about my feelings or what's going on in my family, that sort of thing, then I'm not going to be able to identify and talk about my own feelings, which again turns all those feelings inwards and leads to that impulsivity. Just for a basic example, again, with the substance abuse, we keep going back to that because that's a lot of what you see in families in this situation. Families who have a member who have a substance abuse problem usually keep that a secret. They don't talk about it. You don't go to church and say, oh, my husband has an alcohol problem. Not usually. Or you don't go to work and say, yeah, I was out drinking last night. That's why I'm late and that's why I have a hangover. So I'm going to have difficulty doing my presentation today. And then, of course, that extends to the children. Don't talk about mommy's alcohol problem. Don't talk about daddy's drug problem. And so that becomes a family secret. And the child has difficulty differentiating between what is it safe to talk about and what am I going to get in trouble for talking about. And then that leads to that impulsivity. And then there's the poor parenting issue. And we briefly touched on this, authoritarian, authoritative, or permissive. But now we're going to talk a little more in depth about that. First, let's talk about discipline. The English word discipline comes from the Latin discipuli, which is where we get the word disciple. Punishment, on the other hand, comes from the Greek poigne and Latin pena, which means revenge. And that's where we get the words pain and penalty. So there's a difference between discipline and punishment, especially when it comes to corporal punishment. What most of the research has shown, I would go so far as to say most all of the valid research has shown, is that reward works better than punishment, especially in the realm of children and parenting. So that's where we get into the authoritarian, authoritative, and permissive. Authoritarian parents rely primarily on punishment as their means of discipline instead of reward. Authoritarian parents tend to have the my way or the highway approach. Authoritative parents, on the other hand, tend to use reward instead of punishment. Now, that doesn't mean every time your child behaves properly, you go out and buy them a gift or a prize or something like that. You can be authoritative by giving rewards by just saying, good job, I really appreciate the fact that you were so well behaved in that situation or that you did the right thing. So, for example, at the end of the day, when you're tucking the child in for the night or maybe while you're having dinner, you can sit down with the child and find something good to say about them. I noticed you didn't get into trouble today. I noticed you did your homework today. I'd like to thank you for playing so well with your sister. Those sorts of things can be the rewards we're using in the authoritative parenting. Finally, the permissive style, which is just the parent says, I don't care what you do, you're on your own, you go do whatever you want. Now, when authoritarians start hearing about authoritative parenting, they think, well, if you don't spank your child, if you don't hit your child in the name of discipline, then you're being permissive. That's actually not true. Authoritative parents are actually stricter than authoritarian parents. And the primary reason for that is that punishment doesn't work. So if you're an authoritarian parent, you punish your child for doing something, and then they do it again. So you say, well, the punishment didn't work, so I'm going to increase the punishment. And then they do it again. And then you keep increasing and increasing the punishment until it gets on the edge of becoming child abuse. And when it gets to that point, most authoritarian parents will say, well, I just don't know what to do with this child. They think that the only means of discipline is to hit the child. then when hitting the child doesn't work, then what do? So they think that you're being permissive if you don't hit the child. Authoritative parents, on the other hand, will say, I'm going to reward you for doing a good job. And that, again, doesn't mean you go out and buy them a present or you give them gifts when they act well. It could be as simple as thanking them for a job well done or just noticing when they behave. And authoritative parents tend to be more strict in that regard because they're not worried about turning their style of discipline into child abuse, because they don't have to keep escalating, because authoritative parenting actually works. So when you're looking at the environmental factors, check to see if poor parenting is a factor, especially if corporal punishment is used, because parents tend to minimize the amount of corporal punishment they're using. And so if they use corporal punishment more than once or twice a week, then they could be minimizing, and it could be edging into the area of child abuse. Now, why does parenting that uses punishment border on looking like ADHD? Because hitting someone is trauma. Regardless of whether or not you think that hitting a child is okay, scientifically, we know that hitting a child is a traumatic event. And if you don't believe that, just ask yourself, as an adult, if someone hits you, would you be traumatized? Even though we might think that it's okay to spank a child or to hit a child in the name of discipline, it still has a traumatic impact on the child. And that traumatic impact occurs in the areas of the brain that are responsible for emotional regulation, for paying attention, for making good decisions. All of those things that are affected when you diagnose ADHD. So rule out the poor parenting before you diagnose ADHD. And of course, it doesn't all have to be physical abuse. It could be emotional or verbal abuse as well. So when you're looking at child abuse or neglect, first rule out, is there any verbal abuse in the home? A lot of yelling, a lot of screaming. Emotional abuse in the home, telling the child they're worthless, destroying the child's self-esteem, those sorts of things. And then we've already talked about the physical abuse in the home. Rule that out. Sexual abuse in the home. That's another one of those family secret things that nobody talks about. So you have to be a little more careful with the sexual abuse in the home. And if you're talking to a child, hopefully you'll know this already, but just to make sure, if you're talking to a child and asking about sexual abuse, make sure that the parents are not in the room when you do that, because the child is not going to talk about it with a parent in the room, especially if the parents are the ones that are doing it. And then, was there any witness of domestic violence? Did they see domestic violence going on? And again, that's not necessarily just in the home. It could also be in the neighborhood. Maybe the parents are not engaging in domestic violence, but maybe the child is in a neighborhood with a lot of crime and still witnesses a lot of that. And then neglect, food, clothing, shelter, basic necessities, truancy, those sorts of things. And the reason those can look like symptoms of ADHD is if you're hungry, you're going to have a difficult time concentrating at school. If you don't have your basic necessities being met, your mind is going to be on getting those basic necessities met, not on doing your homework, not on controlling your impulses, not on making good decisions. Let's zoom in on this corporal punishment a little bit just so we can differentiate. And again, hopefully made the point by now, but ADHD symptoms are similar to trauma symptoms, and corporal punishment is trauma. Whether or not the parent thinks it is, it's not up to the parent, it's the child that determines whether or not it's traumatic. So think about FIDO, FIDO, frequency, intensity, duration, and objects used. How often is corporal punishment being used? If it's being used more than once a week, then I start looking into the abuse column here. This is getting close to abuse. Intensity, how hard is the child being hit? And where is the child being hit? So for example, how intense is the punishment? Is it once or twice? Things along those lines. I used to do a thing when I spoke on corporal punishment in children where I would ask for volunteers among the audience, because one of the things I used to hear a lot was, well, Spanking is different from physical abuse. So I would, when I was doing the presentation, ask for volunteers to come up and let me hit them, and they can tell me when it's crossed the line from spanking into physical abuse. And of course, I would never, number one, have done that to anybody, but I was just doing that to make a point. Number two, of course, nobody ever volunteered to come up to be hit. No adult wants to be hit either. So, of course, the child doesn't want to be hit. And I finally stopped doing that because I had an attorney tell me that even offering for volunteers to come up and be hit could be considered assault legally in some situations. So I no longer use that thought experiment as an illustration because even the threat of hitting someone is assault in many jurisdictions. So we're looking at intensity. I would say that any hit is too intense for a child. But again, if you're ruling it out with parents whose primary form of discipline is corporal punishment, you want to look at the intensity. How hard and how often are they being hit? And then the duration. How many licks are they getting there? Is it one or two swipes on the bottom with a bare hand? Or are they being hit all over their body for 5 or 10 minutes? Objects used. Are they just using an open hand, or are they using a hairbrush, a shoe, a ping pong paddle, a leather belt? Anything that leaves a permanent mark crosses over into child abuse in most Child Protective Services definitions of child abuse. And then finally, where is the child being hit? Most people hit children on the buttocks. Now, the theory behind hitting them on the buttocks is because there's less areas of less potential for injury there. You're less, if you're hitting a child in the face, you could break their nose or put an eye out, that sort of thing. If you're hitting them on the buttocks, you're just bruising their rear end. But what's not being considered there is that area of the body is a sexual area. When they're educating children about sexual abuse, this is my no-no square, you can't touch me there. The buttocks are included in that. If you were to grab a child on the buttocks out in public, you would be arrested for sexual abuse, rightly so. But if you're hitting a child, you're hitting your own child on the buttocks, that's not considered sexual, although it should be because that is a sexual area for a child. Keep that in mind as well. In terms of injury and everything else, you do want to rule out whether or not the child is being hit in the head, hit in the face, those sorts of things. Let's talk a little bit more about attachment disorders. The first type is insecure attachment, and that manifests often in reactive attachment disorder. And here's some symptoms of that. Child avoids eye contact, doesn't smile, doesn't reach out to be picked up, rejects your efforts to calm or soothe or connect with the child, doesn't seem to notice or care when the parents leave them alone, cries inconsolably, and there is that element of impulse control that could be misdiagnosed as ADHD, the inability to regulate and modulate emotions. Doesn't coo or make sounds, of course that's with infants. Doesn't follow you with his or her eyes. In other words, they're self-contained, that's emotional detachment that we're talking about, emotional cutoff. They're kind of not capable of relating to other people emotionally. Isn't interested in playing interactive games or playing with toys. And then spend a lot of time rocking or comforting themselves. These children are basically turned inwards. Their focus is inward because if they try to reach out, they have been cut off. They have been neglected or abused. So they turn inwards and develop that reactive attachment. And that you can see, I'm sure, how that could lead to impulsivity, inability to concentrate, inability to pay attention. Next is post-traumatic stress disorder. Now, this is actually a differential diagnosis, but I included this in environmental factors because usually, well, I would say pretty much always, there has to be something external to the child or to the adult who has experienced trauma that is causing a diagnosis of post-traumatic stress disorder. So that is an environmental factor. So the risk for post-traumatic stress disorder is increased by a factor of 4 in individuals with attention deficit hyperactivity disorder, ADHD, as compared to those without the disorder. And that comes from a study by Spencer in 2016. And the risk for diagnosis of ADHD is twice as high in individuals with a PTSD diagnosis as compared to the general population. Again, that's Spencer. So what we're saying here is that there's a great deal of comorbidity with PTSD and ADHD. Now, again, that might be a chicken or egg situation. Correlation does not prove causality. Post-traumatic stress disorder didn't cause the ADHD. ADHD probably didn't cause the post-traumatic stress disorder, but it's still not outside of the realm of possibility that one caused the other. And this comes from Ansel in 2013. The lifetime prevalence of PTSD was significantly higher among adults with ADHD compared with controls, 10% versus 1.6%, in other words. The comorbidity of PTSD and ADHD in adults leads to greater clinical severity in terms of psychiatric comorbidity and psychosocial functioning. In other words, if you have both, you have more severe symptoms of both. It's a synergistic effect. The PTSD symptoms exacerbate the ADHD symptoms, and the ADHD symptoms exacerbate the PTSD symptoms. The familial co-aggregation of the two disorders suggests that these disorders share familial risk factors, and that their co-occurrence is not due to diagnostic errors. In other words, if you have both of these disorders comorbidly, then there are probably some familial risk factors going on that are in play there. In other words, there's something happening, whether it's environmental or whether it's genetic, that is contributing to both of these diagnoses. Now, of course, ADHD is usually a malfunctioning ability to self-regulate, poor impulsivity, inability to concentrate, inability to regulate emotions, that sort of thing. PTSD is trauma usually caused by people who lack the ability to self-regulate. If a child experiences trauma from a parent, that parent has the ability or lacks the ability to self-regulate and acts impulsively towards the child, probably striking them, probably emotionally abusing them, that sort of thing. So is that a coincidence? Harrington in 2012 did a study with military combat veterans with high exposure to traumatic events, and the results show that 54.5% met the criteria for current PTSD, and 11.5% of them also met the criteria for current adult ADHD. What is the relationship there? Let's talk about the relationship between the Adverse Childhood Experiences study and post-traumatic stress disorder. The ACE study, as they call it, their Adverse Childhood Experiences, this was a study by Brown in 2017 that looked at the relationship between ACE scores and ADHD. What the study found was that children with ACE scores of 2, 3, and greater than 4 were significantly more likely to have moderate to severe ADHD. Children with ADHD have higher ACE exposure compared to children without ADHD. So for those of you who have not heard of the Adverse Childhood Experiences or the ACE worksheet, there is one in the documents that came with this course, so you might want to download it now if you haven't done so already and get it out. We're going to go over it briefly and discuss what each of these mean. So if you haven't already gotten it handy, you might want to pause the video and go get that now, and then resume the video when you have the sheet in your hand. Okay, this is the Adverse Childhood Experiences Questionnaire. If you're not familiar with this, there's a wealth of information online that you can look up about the history of this and the significance of it in mental health. Hopefully by now a lot of people in the mental health professions are familiar with it, but just in case, we're going to go over it. Let me read it first and then we'll talk about it a little bit. This questionnaire will be asking you some questions about events that happened during your childhood, specifically the first 18 years of your life. The information you provide by answering these questions will allow us to better understand problems that may have occurred early in your life and allow us to explore how these problems may be impacting the challenges you're experiencing today. This can be very helpful in the success of your treatment. And just for the record, there are only 10 questions on this sheet, so it's a very quick and very helpful diagnostic tool to be able to look at when you're diagnosing ADHD. So, for every question that the patient answers yes, you enter a 1. So the first question, did a parent or other adult in the household often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? Yes or no? Now, what does that word often mean? Just as a general rule of thumb, I use 3 times a week or more. So did a parent on average swear at you, insult you, put you down, humiliate you, or make you afraid that you were going to be physically hurt 3 or more times per week on average? Next question. Did a parent or other adult in the household often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? And again, often 3 or more times a week. And the had marks or injured, that is a mark that lasts more than 24 hours. So if you were bruised, or if you had like a mark from being hit on the legs with a belt, or a swollen lip, or anything along those lines. Then, did an adult or person at least 5 years older than you ever, and this is ever at all, not often, but ever at all, touch or fondle you, or have you touched their body in a sexual way, or attempt to actually have oral, anal, or vaginal intercourse with you? Yes or no? And again, if you're doing this assessment with a child that is old enough to understand the questions, you want to make sure that no parents are in the room so that the child will be free or feel free to answer. Number 4, did you often feel that no one in your family loved you or thought you were important or special? Or your family didn't look out for each other, feel close to each other, or support each other? And you can see where we're looking there for those emotional cutoffs, those fused relationships, that triangling, all those things we discussed earlier. And again, often a good rule of thumb is 2 to 3 times a week at least. Did you often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you? Or your parents were too drunk or high to take care of you, or to take you to the doctor if you needed it? Number 6, were your parents ever separated or divorced? Yes or no? Number 7, were any of your parents or other adult caregivers often pushed, grabbed, slapped, or had something thrown at them, or sometimes or often kicked, bitten, hit with a fist, or hit with something hard? So we're again looking for that domestic violence. The trauma doesn't have to be done to the child. It can also be trauma that was witnessed. And then finally, ever repeatedly hit over at least a few minutes or threatened with a gun or a knife? Number 8, did you live with anyone who was a problem drinker or an alcoholic or used street drugs? And again, this is under 18. Number 9, was a household member depressed or mentally ill, or did a household member attempt suicide? Number 10, did a household member go to prison? And that again is when the child was under 18. These guidelines here are just coming from the facility where this questionnaire came from, but they're still good guidelines, so I'm going to go over them here on page 3 of the handout. Beginning June 1st, 2019, the ACE questionnaire shall be given to all adults 18 and older who are seeking behavioral health services. And that's the name of the agency there. And of course, the reason for that is not only does this help you with a diagnostic differential for ADHD, it's also indicative of a wide variety of mental health indicators. And not only mental health indicators, but physical health indicators. If you have a certain number of ACEs on your questionnaire, you're at greater risk of things like substance abuse, heart disease, smoking later in life, all of these health risk factors. And if you're interested in learning more about that, it might be worth it looking into taking a course on the Adverse Childhood Experiences questionnaire. The ACE questionnaires to be given at the time of clinical assessment are at the initial clinical assessment for new clients and for currently admitted or open clients at all clinical assessment updates completed as a part of the service plan for a 6-month treatment update. What does all that mean? Basically, it just means make sure that sometime within the first session or two that you give your clients an ACE questionnaire. And this is to ensure ready access to a therapist should one be needed to address any issue that might arise from revisiting childhood trauma. And this is a self-administered instrument and shall be completed by the individual seeking services without intervention from the staff. In other words, the staff can't reframe the question or give explanation regarding the intent of the question. The only assistance the staff can provide is regard to vision or literacy challenges. And in that instance, the introduction statement and the questions must be read aloud to the individual exactly as written on the questionnaire. To ensure a trauma-informed process, it's important that the introduction statement on the questionnaire is either read by the client or read to the client. Now, of course, if you're working with children, as you probably will be quite a bit with ADHD, if you're trying to diagnose or differentiate ADHD, some of the children might not be able to read the questionnaire. And if that's the case, then you'll have to read it to them. And you have to be careful when you're doing that, not to impose your own interpretation on it, but to read it strictly as written on the questionnaire. The ideal situation would be for the child to be able to do it themselves. But if they can't, then you'll have to do it for them. And of course, scoring is that for each of the 10 questions, the individual will give a yes or no answer. And when scoring, each yes is given 1 point. And these points are tallied to determine the individual's ACE score. Now we're going to talk about whether or not ADHD is overdiagnosed. The United States has the highest rate of diagnosed ADHD, 11%, compared to a rate of around 5% in countries such as Brazil, China, and Europe. This is further complicated by the fact that there is an insurance incentive to diagnose, and other cultural factors could be at play as well, and we'll talk about that in a minute. But the insurance incentive, let's talk about that. The way that the healthcare works in the United States is we don't have single payer, we don't have Medicare for all, we have insurance companies. And as mental health professionals, I'm sure you're aware that if you don't have a diagnosis that you can put on a form somewhere, then you're usually not going to get paid for the service from the insurance companies. So that means that there's an incentive to diagnose. And if you have a choice between diagnosing or not diagnosing and getting paid or not getting paid, then the tendency is to diagnose. Now, of course, it would be unethical to diagnose someone who doesn't have a diagnosis. And I'm sure everyone listening to this course is ethical, but there are incentives to get paid that might be at play unconsciously as a person is diagnosing ADHD. If I don't give this person some sort of diagnosis, I'm not going to get paid. So the pressure's on, so to speak. A lot of the material in this section comes from a book called The ADHD Explosion by Henshaw and Scheffler. If you haven't read that yet, you might want to pick up a copy. There's a lot of good information in it. In that book, they discuss the impact of school accountability legislation as a major factor leading schools to increase their specialty education population. So what does that mean? Well, for example, they focus on North Carolina, where school accountability legislation was enacted that specified rewards for schools performing up to a standard and penalized those that did not. So in other words, if the school incentive program works along these lines, that the more success you have, the more money you get, then naturally the tendency is going to be to try to have more successful students. Now, while this is well-intentioned, it penalizes the schools with the most problems. If you have a lot of students who have problems, then your students' test scores are not going to be as high as some other schools. And then that means that the schools that have the higher scores are going to get the money, and the schools that need the money are the ones with the least resources, the ones that are producing the students that don't perform. And then this critical accountability measure was measured only by academic test scores. And Shaw and Scheffler suggests that to maximize test scores, schools ought to have underachieving students diagnosed and treated for ADHD, so they'd be put on attention-enhancing medications and or receive testing accommodations. So in other words, schools have an incentive to have students diagnosed with ADHD because then they can be put on all these attention-enhancing medications or receive a testing accommodation, and that causes the school scores to go up. So in other words, the more diagnosis of ADHD you have in the schools, the more likely it is to have higher performing school scores. And that's the only measurable or the only critical accountability measure was academic test scores. And people and students and children are more than just how well they perform on a test. There are a lot of other things to take into consideration other than just how well they perform on the test. So you can see that there's a problem right here, right at the start. And to back up the suggestion in the book, they report research indicating a positive correlation between the increasing accountability demands and increases in an ADHD diagnosis over the years. So what we're saying here is the reason that the United States has a diagnosis that is twice as high as most other countries. Does that have anything to do with this school incentivization program? And that data, Hinshaw and Scheffler report, increases as high as 59% for ADHD diagnosis among youngsters from low-income homes after the launching of school accountability laws, compared to a less than 10% increase among middle and high-income children. And those who argue that overdiagnosis of ADHD is not a problem suggest that such a discrepancy is an indication of a long-standing failure to address ADHD among low-income populations. Hinshaw and Scheffler argue that the discrepancy is better explained by school accountability policy. So we have two possible considerations here of why the ADHD diagnosis went up after they implemented this school testing stuff. The first is that schools are incentivized to diagnose ADHD because that way they get more money. Or the other is that there's been a long-standing neglect of the poorer and lower income families when diagnosing ADHD. So their argument is that it's better explained by school accountability policy, these more money for more higher test scores. Another possible factor that we haven't talked about is that maybe just the United States is better at diagnosing ADHD than these other countries around the world. That's a little iffy to me because most countries have equal or better standards of diagnostics than the United States does, especially given the state of healthcare in the United States versus the rest of the world. So I'm not sure that that would be the reason, but it is a possibility. It could just be that the United States is so much better than the rest of the world at diagnosing ADHD that we have twice the rate of everybody else in the world. So that's it for the course materials. Now the next video is course summary and review. We'll be going over the materials you need to know for the post-test. Key points to remember for the test. About 5 million children globally have a current diagnosis of ADHD. And according to the National Survey of Children's Health from 2016, about 1 in 10 children on average in the United States have a diagnosis of ADHD. That's about 1 in 20 for the rest of the world. ADHD symptoms overlap with the symptoms of many other disorders, and that makes ADHD difficult to diagnose sometimes. In addition to clinical factors, some other factors to consider when diagnosing ADHD include the psychological aspects. In other words, could it be another disorder with symptoms similar to ADHD? General medical conditions, in other words, are there any physiological or physical reasons that could account for the symptoms better than an ADHD diagnosis? Environmental factors. Are the symptoms a result of the patient's environment? And are the symptoms present globally or specifically? And what we mean by that is if you have ADHD symptoms, then they should be present all the time or most of the time, unless you're taking medication for them. Whereas with a lot of these other general psychological or diagnostics, the symptoms are present only intermittently or only at certain times. Like, for example, if it's the symptoms are being caused by diabetes, then it might be because of the time of day. The symptoms only show up around mealtime, or the symptoms only show up during periods of intense hunger. Or if it's due to something like bipolar disorder, then the symptoms only show up when the patient is manic, that sort of thing. And then comorbidity. Are there other things going on in addition to ADHD? It could be something other than ADHD, or it could be that the patient has ADHD and something else. So you want to rule those both out. One thing to consider, especially if you're working with low-income patients, is that PTSD is often misdiagnosed as ADHD. And diagnosing PTSD as ADHD is possibly the most misdiagnosed. Before diagnosing ADHD, always check for PTSD symptoms and/or a history of trauma. And a good way to do that history of trauma is with the ACE questionnaire that we've already talked about. So that's a good way to say, okay, it looks like you've had some childhood experiences that might tend to lead you toward a diagnosis of PTSD. So let's rule out these PTSD symptoms before we diagnose you with ADHD. And a good rule of thumb for differential diagnosis is to ask whether the symptoms come and go or whether they're stable for the reasons that we already talked about. If they're pretty much stable, then it's probably ADHD. If they come and go, then you want to rule out those other causes, physical causes, differential diagnosis, environmental factors. And this rules out diagnoses with periodic symptoms like bipolar disorder and substance abuse disorders we've already talked about. And of course, when diagnosing ADHD, always take these factors into consideration. Could it be another disorder with symptoms similar to ADHD? Could the symptoms be better accounted for by a medical condition? Are the symptoms the result of the patient's environment? Are the symptoms present globally or specifically? And are there other things going on in addition to the ADHD? When diagnosing ADHD, always take the environmental factors into consideration as well. Environmental factors that could lead to a misdiagnosis of ADHD include unsafe or disruptive learning environment, family dysfunction, poor parenting, child abuse or neglect, corporal punishment, and attachment disorders. And also, there's an interaction there between environment and diagnosis. In other words, PTSD is a psychological diagnosis, but the environmental component of PTSD is a traumatic event, one or more traumatic events that triggered the PTSD. And it could still be ongoing as well. There could be ongoing environmental trauma that is happening that is contributing to the symptoms. The US has the highest rate of diagnosed ADHD in the world, 11% compared to a rate of around 5% in countries such as Brazil, China, and parts of Europe. So our diagnosis of ADHD is more than twice as high as most other countries. This could be the result of overdiagnosing, or it could be that the United States has more and better trained medical professionals at diagnosing ADHD. In their 2014 book, The ADHD Explosion, Henshaw and Scheffler discussed the impact of school accountability legislation as a major factor leading schools to increase their special education population. In other words, the more ADHD diagnoses they have in a school, the more likely they are to get more federal and state funding for schools. And Shaw and Scheffler report increases as high as 59% for ADHD diagnosis among youngsters from low-income homes after the launching of school accountability laws, compared to a less than 10% increase among middle and high-income children. In other words, there's a disproportionate amount of ADHD diagnosis in the lower income families. That concludes this course. Good luck on the test. You'll have 3 chances to pass it with a score of 80% or higher.